طيب بسم الله الرحمن الرحيم. Well, thank you for bearing to listen to me again today, so appreciate that. Okay, so I was asked to talk about first-line therapy in CLL, and that's what the talk is going to be about. Well, first of all, we have to understand that it's important to keep in mind that CLL patients, there's this notion that if a patient with CLL doesn't need therapy, that he's pretty much a normal person. Well, that's actually not true. That's not true, has been shown over and over again. Even for the patients who never needs therapy, they are absolutely normal people. Their overall survival still doesn't match to normal population. There are multiple problems related, or multiple problems that CLL causes those patients in terms of infections, secondary malignancies that really affect the outcome of that patient population. Another thing that we understand pretty well right now, I think everybody knows that from their practice, that CLL is a disease of the elderly. Many of the patients with CLL come at advanced age. Median age is above 70 years old. And only minority of those patients are actually young, less than 55 years old. Another fact about CLL is that many patients with CLL have comorbidities, and that's also important to keep in mind. Real life data shows that at least half of those patients have one major comorbidity, and a good number of them have multiple comorbidities. And another fact that we also have to keep in mind, that until sometime in the 1990s, when chemotherapy was challenged against chemoimmunotherapy, I guess there was a trend at that time to include only patients who are fit and healthy to tolerate such therapies. So you will look at all trials that investigated FC versus FCR, chlorambucil versus FC, and what have you. And you look at the median age for the patients included on those trials, it doesn't really represent what the real life situation is. Now, fortunately enough, this has changed recently. In Saudi Arabia, the situation is not that much different. We looked at our data. Dr. Amuna Adam is not here. I take her data actually. So this is our local institutional data for the patients with CLL diagnosed over the last 15 years. And our patient population also, being even a referral center, the majority of our patients are referred from outside. Still, good number of them are elderly, patients above 60 years old. Also, many of them are with comorbidities. Major comorbidities like cancers, renal impairment, liver failure are present in almost half of those patients. This is real life data from our hospital. Renal impairment is present, renal failure is present in 15%, so that's also more than what you would expect in normal population people. Also, from our data, P53 mutation matches with what's reported internationally, which is 10% of the population having 17p deletions sometime during their disease. Again, just to emphasize the same idea of what if patients don't need therapy initially? Well, still, those patients are not healthy. Half of our patients didn't need therapy initially. And I'll come back to this actually. Let me just show this slide. And the overall survival for that patient population is not different from the people who were treated. So again, people who didn't need therapy, didn't meet the criteria of therapy initially, their overall survival was not any worse or better than the people who needed therapy and were treated. And I think this just tells us one message, which is they didn't do much better anyway, because they either fell or succumbed for another morbidity, or when they needed therapy, their outcome wasn't any better. From our data as well, again, comorbidities did affect outcome. People with multiple comorbidities had significantly shorter overall survival than patients with one comorbidity or more, or none, sorry. We all know this, obviously. Not all patients with CLL need therapy. There are clear indications right now by the International Working Group for CLL that outline what are the indications of therapy. Those apply for both general practice and clinical trials. Not much difference from that point of view. I guess it's also important to know that International Working Group for CLL puts some criteria that would include people on clinical trials for CLL, but maybe in clinical practice, we're not, if we are faced with one of those situations, I don't blame people if they decided to wait a little bit. So things like related to the size of lymph node, for instance, absolute lymphocyte count doubling time, for instance. Yes, it's a predictor that those patients will need therapy soon in the near future, but it's not, you know, a life or death situation where if therapy doesn't start in the next month, that patient won't do very well. So we have to differentiate between criteria that are there to unify eligibility for clinical trials versus, you know, real criteria to treat people on real life situations. International Working Group for CLL also puts criteria of workup pre-therapy for those patients, and that workup as well is standardized right now. Indeed, all guidelines are built upon that workup. So things like 17p deletion, p53 mutation, and immunoglobulin mutational status. This is standard of care right now, not only in clinical trials. That's basic standard of care for daily practice, because as I said, all guidelines are built upon this information currently. So, but some other stuff is not. Imaging, for instance, is not. The imaging is not indicated for clinical practice. It's indicated for clinical trials, but it's not indicated for clinical practice. Up till this point, assessment of response is actually physical therapy, physical exam, when it comes to lymph node sizes assessment, for instance, in real life situations. So why some of those are important, we all know 17p deletion is not only a prognostic feature, but it's also a predictive feature, at least in chemoimmunotherapy data. A bunch of patients with untreated p53 mutation, median survival for those patient population is pretty bad, whether or not they have 17p deletion or sole p53 mutation. We have also to understand that this patient population with 17p deletion or p53 constitutes a bunch of patients where there's 5% of those patients could harbor p53 mutation without never having 17p deletion. And this is just emphasizing the importance of sending molecular on those patients, not only sufficing with the 17p FISH testing. Unfortunately, we even don't send it, but we are probably missing some of those patients because of this. As I said, why is that? Because right now there's no role of chemoimmunotherapy whatsoever in p53 mutated patients or 17p deleted patients or both. Those patients don't do well with chemoimmunotherapy. Their outcome is terrible, and they have done much better with novel agents. With Ibrutinib, for instance, patients who are treatment naive, so if Ibrutinib used up front for those patients, their outcome is not different than patients who do not harbor 17p deletion or p53. In the relapse refractory setting, the story is a little different. And that just tells you that if those agents are introduced later in the disease, so they are not introduced upfront therapy, we actually affect the outcome for those patients. So that's why testing those upfront when the patient needs therapy is obviously of utmost importance, because treating them with chemoimmunotherapy just to discover later that they have p53 mutation would definitely affect their chances of responding to Ibrutinib in this example. Immunoglobulin mutational status, why it's standard of care upfront? Again, it's a clear prognostic feature, has been established for years right now. For patients who are untreated with CLL, it does differentiate between mutated and unmutated. And also in the realm of chemoimmunotherapy, it is a predictive factor. not so much as the case with the novel therapies. So Dr. Rossi, for instance, back in 2015, published a model of cytogenetics as a predictive model for response to chemoimmunotherapy, and he came up with three groups of patients. One he called low-risk population without the 11q or with mutated immunoglobulin, and another group of patients who he called intermediate risk group, who have either unmutated status or 11q, or high-risk population with 17p deletion. And with chemoimmunotherapy, you can break down the patient population nicely into three groups. So with chemoimmunotherapy, mutational status is not only a prognostic feature, but it is a predictive feature as well. So it predicts response to therapy. Immunoglobulin mutational status is stable over time. You only need to test it once. You don't need to retest it again. And the testing is usually done through genetic molecular testing. Now, what about mutational status with novel agents? I think there's no, well, we come back again to the Illuminate later, but I think the nicest study that have shown the impact of this is the Illuminate study. Illuminate was built upon the CLL-11, which compared chlorambucil obinutuzumab to chlorambucil rituximab to chlorambucil alone. And so this took the winning arm, which is the chlorambucil obinutuzumab, compared it to Ibrutinib obinutuzumab. Now in CLL-11, obinutuzumab was able to overcome the unmutated negative impact on rituximab treated patients. So obinutuzumab was better than rituximab in unmutated patients. Okay, so see, the antibody mattered here. Now, why this study is important, the Illuminate, because now you are testing two. Is ibrutinib adding anything more to the obinutuzumab in the unmutated? And it does, because you look at the both arms of ibrutinib obinutuzumab mutated compared to chlorambucil obinutuzumab mutated. Obviously there's a difference, benefit coming from the ibrutinib, and then you compare both arms containing ibrutinib, mutated and unmutated. There is still benefit in the mutated arm, which is not seen in the ibrutinib, for instance, Resonate trial, single agent ibrutinib. So there is added benefit in combining them together, and that's why you will see this combination shown as an option in, for instance, NCCN guidelines. So again, backbone for CLL prognostication is the mutational status and 17p and p53 mutation. So frontline options for CLL patients. What determines how we take the decision in frontline options? Obviously, things related to the disease. We've spoken about that, low risk and high risk, depending on the presence, one of those factors. And then issues related to the patient, specifically the age, creatinine clearance, and comorbidities, regardless of how you check the comorbidity. Well, up to 2018, this is what we had. We had, people traditionally breaking down the patient population into three groups, the traditional German way of go, slow go, no go. And within this, we had overlaps. So we had FCR, a winning arm, in patients who are young and healthy. We had BR, an option for patients who are either above 65 years old or with comorbidities, or people with mutated status. Maybe it's an option because it wasn't inferior to FCR. You had chlorambucil anti-CD20 antibody as an option for patients who are older or with comorbidities. And then you had ibrutinib based on the Resonate trial, again for the patients who are older with comorbidities, but not for younger. This is what we have in 2018. So somewhere from 2018 to 2019, this is what happened. First of all, we had Resonate, now a very long update. We have median follow-up of Resonate right now is 60 months, 5 years. So this is added so much to our knowledge. And then we had the Illuminate, Alliance, ECOG, and the CLL14, which we will go through right now. So The NCCN guideline, based on this right now, they've changed their outline. This is the first time NCCN does that in CLL. So now they've broken down the patient population into two groups. Number one, based on age, so 65 and below 65, and with the morbidity index plus renal impairment. So they've had two groups. Patients who are young without any significant comorbidities, they break it down into preferred regimens and other recommendations, and you can see what they have on the list there. You can tell that both lists look very similar. Actually, the differences are very minute between both lists, the people who are younger and older. Only differences is the FCR, the Ibrutinib obinutuzumab in the patients who are older, and the third difference was the chlorambucil anti-CD20 for the patients who are older as a secondary option. But everything else pretty much on that list looks the same. CLL10, you all know it. It compared FCR to BR, and yes, FCR was the winning arm. Remember this, progression-free survival at 3 years for FCR was somewhere in the 70% range. Remember that number. FCR was better in the unmutated, but still wasn't that much satisfactory. And BR wasn't worse in the mutated group. Patients who are younger than 65 benefited from FCR. Patients above 65, BR was not statistically significantly worse. So based on this trial, the ECOG 1912 randomized patients between Ibrutinib, rituximab versus FCR. So which patients? Patients less than 70 years old, because there the winning arm was patients 65, so they've chosen 70 years old, and excluded patients with 17p deletion. So this is an age-directed trial. They're only taking young patients, okay? This is their treatment schema. So Ibrutinib is indefinite until progression here, okay? So yes, the trial was better in its primary endpoint. What's the primary endpoint? Was progression-free survival. And the progression-free survival was statistically significantly better for the IR group than the FCR. The secondary endpoint here was overall survival, and that was also statistically significantly better for the IR, with a absolute difference of 6 more deaths. I call those the 6 deaths that change history. Yeah, I mean, many people do really say, let's be cautious, and it's only the difference is so minute to start really quoting overall survival difference here. But again, the trial only speaks what you intended to speak. This is what they had. They had such a p-value before their, whatever they put their significant value, they got a significant p-value based on whatever criteria they've chosen. But I guess the main point here is the progression-free survival, and the difference is clear. Everybody pretty much benefited. Probably again at 3 years, the progression-free survival with the FCR was 72, so that's compatible with the CLL10, and it was 89.4% with IR. Okay. The patients who benefited the most, it was people who are unmutated status. Their progression-free survival with FCR was 62 only, and it was 90 with IR, so major difference. Patients with mutated status had no statistically significant benefit. So in terms of responses, you do get more responses with FCR in terms of complete remissions, 30% versus 17%, and this is a well-known phenomenon with Ibrutinib because of the issue of lymphocytosis, as well as the measurements of lymph nodes, you know, CT scan versus physical exam. But the overall response rate with Ibrutinib was higher, 95.8%. The CR rate documented by imaging is higher with FCR. But again, this does not translate into benefit in progression-free survival, because we know traditional response criteria in CLL, traditional response criteria are not correlative to benefit when it comes to progression-free survival benefit. The therapy was very well tolerated. You would guess that FCR had more grade 3, 4 toxicities, mainly hematological, neutropenia, thrombocytopenia, and infectious. On the other hand, IR had only 7.1% of infections. On the other hand, IR had more toxicities when it comes to atrial fibrillation and hypertension. And please keep in mind the story of hypertension. And on this trial, hypertension grade 3 and above was 18.5% in the IR. This is a recurring story. And actually, the hypertension story in Ibrutinib is something sort of came new, if you want. We didn't keep much attention about it up front, you know, when Ibrutinib first came. But now it's becoming more clearer that it is occurring, and it's actually correlating with the cardiac toxicities as well in terms of atrial fibrillation. So based on this trial, the authors, as well as obviously people who set guidelines like the NCCN, took it as a standard of care changing therapy for patients who are young, regardless of comorbidities. But obviously you would take people who are healthy to generalize such data. So we come to the majority of the patients, the people who are older or people with comorbidities. And again, from the beginning, we agreed that those constitute the majority of the patients. Again, in the NCCN guidelines, you look at the preferred regimens, they look exactly the same. The only difference between them and the people who are young is the other recommendations. So here they take out FCR, for instance. They introduce Ibrutinib obinutuzumab, as we will see why. They introduce chlorambucil anti-CD20 antibody as an option as well, as a secondary options. So for that patient population, the CLL11, you all are familiar with this. This took patients who are with comorbidities, regardless of age. They took patients with a high Sears score or patients with renal impairment. So again, this is a comorbidity-directed therapy, and it randomized them in between chlorambucil single agent, chlorambucil rituximab, or chlorambucil obinutuzumab. And yes, chlorambucil with obinutuzumab had a higher response rate compared to rituximab chlorambucil, CR and PR, so higher overall response rates. And chlorambucil obinutuzumab was better than rituximab chlorambucil in progression-free survival. Progression-free survival improved by almost 10 months, from 15 months to 26.7 months. So based on this, we will talk about what happened in the last year. Well, first thing is the long follow-up of RESONATE. RESONATE-2, which took patients who are elderly with comorbidities. Median age was 60 there. Above 60, actually, 60 plus. And it randomized them between Ibrutinib versus chlorambucil single agent. Now we have 5 years median follow-up on this trial. I think the most important point here is that at median follow-up of 5 years, 58 or 60 almost % of the patients are still taking Ibrutinib. So in the long run, you know, it means that more than half of those patients are still either to tolerate therapy with response or with the disease being under control. And that benefit comes across the board, regardless of the cytogenetics and mutational status. I think that's also important to keep in mind, which is the issue of toxicities. We also learned from this that the majority of the toxicities we worry about, mainly the atrial fibrillation and hemorrhage, they happen up front, usually within the first couple of years of therapy, and the longer the patient progresses in therapy, the more that those decrease. Hypertension, again, this is, I think, an important theme. Hypertension does occur more than 30% of those patients, and it can get to grade 3 hypertension. And actually, I was reading a trial in cardiology from Ohio State just yesterday. Some of it could be hard to treat, so it should not be taken lightly. And there is some correlation between the occurrence of hypertension and the occurrence of atrial fibrillation. So that's something, for instance, I've kept more attention about recently. So there is also there was always this argument about, if you have an older patient with some comorbidities who have mainly pancytopenias, does using a novel agent, and in this case ibrutinib, is it of benefit? And it is, yes. You know, those novel agents not only improve or progression-free survival or overall survival, they do improve quality of care. So for instance, the anemia and the thrombocytopenia, which do affect how those patients live with their disease. So based on all of this, first of all, we have the Alliance trial. The Alliance trial took patients who are elderly, so above 65, again, remember, this is above 65, who are otherwise pretty much healthy, and they randomized them between ibrutinib, IR, or BR. So why above 65? Because say CLL10, we said above 65, BR was not inferior to FCR. So they are asking in that patient population who are healthy otherwise, would you still treat them with BR or would they benefit from IR? Again, the main primary endpoint here was progression-free survival. And yes, IR is better than, or R, or I single agent without rituximab is better than BR when it comes to progression-free survival. Median progression-free survival was not reached, and it was 43 months with the BR arm. Overall survival, there was no difference. That benefit happened regardless of 17p deletion, 11q, or patients with normal cytogenetics. Again, the same theme here. Patients with unmutated status had the worst outcome with BR. Patients with mutated status, the difference did not reach statistical significance yet, but the benefit, increased progression-free survival, happened with patients mutation or unmutated status regardless. So the hazard ratio was 0.51. Again, obviously BR is well tolerated than FCR, but still it has more hematological side effects than IR. And non-hematological side effects are more common with IR, mainly the hypertension, which is also reported at 34% of the population, as well as the atrial fibrillation, which is reported up to 10% of the population. So based on this, again, the authors as well as NCCN took it as an option. Again, there is no benefit from adding rituximab here, so ibrutinib as single agent would suffice as an option for patients above 65 years old as being preferred option. The third patient population are people with comorbidities, with or without age issue. So again, this is imitating CLL11. So they're comparing to chlorambucil obinutuzumab and comparing it to ibrutinib obinutuzumab. Again, indefinite therapy, and the primary endpoint is progression-free survival. And yes, progression-free survival in that patient population is better with ibrutinib obinutuzumab. No difference in overall survival. After median follow-up of 40 months, 60% of the population still remain on ibrutinib. The median investigator progression-free survival was not reached for the IG. It was only 22 months for the GC. Look at the one on the bottom right is the issue of mutated IG, unmutated IG, and then mutated chlorambucil G and unmutated chlorambucil G. Just tells you the huge difference between the unmutated and mutated using chemoimmunotherapy. So in that patient population, chemoimmunotherapy should not be an option. There's a huge difference in the outcome. And that's another reason in this trial that probably obinutuzumab is adding something to ibrutinib for the patients who are unmutated. That's what I believe. And I guess NCCN believes as well, because they kept it as an option, secondary options for that patient population. Again, toxicities is pretty much similar to what we've mentioned before. So the fourth trial was the CLL14. Again, CLL14 took patients with comorbidities. So this is the theme of the CLL11, patients with sears above 6 and creatinine clearance less than 70, and randomized them between Venetoclax obinutuzumab versus chlorambucil obinutuzumab. Here, just keep in mind that Venetoclax is time-definitive therapy, so it stops after 1 year of therapy. so 12 months of Venetoclax only. And at 24 months, 2 years of follow-up, the median progression-free survival was 88% versus 64% for chlorambucil obinutuzumab with a significant hazard ratio of 0.35. This obviously benefit, again, mutational status, although patients with mutated status, chlorambucil obinutuzumab, it seems that with time definitive therapy, the outcome probably is not that much different there, probably because you're restarting therapy on them as well. So we don't know. But with P53 was obvious, the answer, no need to repeat that theme. Grade 3 and 4 neutropenia occurred in 52.8% of the patients in Venetoclax obinutuzumab group and 48% with chlorambucil obinutuzumab. Infections were pretty much not that much different. In general, the therapy is well tolerated, and the benefit it adds is that it's time definitive therapy. Finally, Ibrutinib, if combined with Venetoclax, does achieve very high response rates, responses that we have not seen in any of the previous trials, neither with chemoimmunotherapy nor with novel agents with immunotherapy. This theory is behind the Captivate trial, which I think is an important trial to keep in mind. Captivate takes treatment-naive, young, healthy, and gives them Ibrutinib and Venetoclax, and it's time definitive therapy for patients who are MRD negative. So it does stop therapy after a while. I think the point here is just keep in mind the responses. You do achieve very high MRD negativity, up to 90%, which is very high, very high. And I think this is something that to keep looking for in the future. Now, what does that all mean? You know, I mean, just at the end of the day, how do you take all this to our clinical practice? You may have heard about Karl Popper. Karl Popper is a philosophist. He lived in the 20th century, died sometime in the 1990s. He spoke so much about the philosophy of science. He really always questioned what's the validity of scientific methods and really reaching answers. And he once said, Karl Popper, that every solution to a problem always creates unresolved problems, and that's important to keep in mind. And he also said that science may be described as the art of systematic oversimplification, and that's very important to keep in mind. You know, it's not just about running a trial and getting that arm A is better than arm B. Yes, this is what you ask the question, you get the answer. But things could be a little more complicated than we look at it. You know, for instance, since we started using Ibrutinib and Venetoclax, right now we are facing mutations that we never got to know about before. So in Ibrutinib, BTK mutations acquired, and Venetoclax acquired BCL2 mutations. Those mutations are creating clones that we didn't encounter before with CLL. So with chemoimmunotherapy, you usually pick up P53 clones. With Ibrutinib, right now you're picking up BTK mutated clones. With Venetoclax, you pick up BCL2 mutated clones. So you're technically having 3 different diseases that we didn't even have before. So how do you compare those patients' populations together? You know, the traditional way of thinking right now, we are thinking of CLL as sequencing therapy. You give chemoimmunotherapy, you get P53, you give Ibrutinib, you get BTK, then you get Venetoclax, and you get some sort of a clone that is probably something that is very resistant to any subsequent therapy. You know, how about giving all those together? How about giving chemoimmunotherapy or immunotherapy with Venetoclax and Ibrutinib all together, which is what we call jive? Maybe you get a different disease. How are we going to answer those questions? That's, I think is the future of CLL. And please keep eye on what's happening in this ASH. Look at the CLL13. I don't think they will have some data about it, not too much, so keep it in mind. This is the jive, which is comparing 4 arms, one of which has 3 drugs, Venetoclax, obinutuzumab, and Ibrutinib. So keep eye on that. Keep eye on the the FLAIR trial, which is also time definitive therapy tailored based on the time you need to achieve MRD negativity. So I think that's an important trial to keep in the future. I think they're presenting the IFCG. This is the MD, and there's some people, they're presenting follow-up data, which is also time definitive therapy, combining both chemoimmunotherapy and novel agents based on MRD response. So that's a novel way to deal. They treat with IFCG, then depending on the MRD status, they give a novel agent for definitive therapy. Keep eye on this trial. It's Ibrutinib with Venetoclax and obinutuzumab, phase 2 trial. Based on this, they are having their randomized trial, the Ibrutinib people. So again, I think the future of CLL, this is where it's moving. But where we stand right now, 2019, is what we have talked about. And then based on each patient, clinical criteria, side effects that you fear, each one of those drugs has certain side effects. I won't use Ibrutinib with a cardiac patient, known cardiac patient, for instance. Maybe I would be more cautious. Maybe BR would be better for them. So clinical judgment here obviously will play a major role. Not all patients are equivalent. That's what we try to say. And thank you very much.